Emergency surgery refers to a surgical procedure that must be performed immediately and without delay to preserve life, prevent the loss of a limb, or maintain functional capacity. These conditions are typically life-threatening and require urgent intervention. For example, a ruptured uterus, a ruptured spleen, or a ruptured ectopic pregnancy. So, in an emergency, the preoperative preparation is limited to basic essentials. So the aims for an emergency preoperative nursing care includes to prepare the patient physiologically, psychologically for the emergency surgery, to resuscitate the patient before surgery, to relieve pain, and to prevent complications such as intestinal necrosis. Patient assessment and resuscitation involves obtaining a focused history relevant to the patient's current condition to guide resuscitation and surgical intervention. Conduct a rapid evaluation of the patient's level of consciousness and gather brief details about pain, including its location, onset, cause, and any recent food intake. Assess the airway, breathing, circulation, and hydration status promptly, addressing any abnormalities immediately to restore normal body function. To ensure the patient's stability and safety, airway, breathing, and circulation must be assessed and managed. So under airway, you need to assess for any obstructions such as foreign bodies or secretions and clear them through suctioning and repositioning. Gently clean vomiters with a clean cloth to avoid trauma. Under breathing, you need to observe chest wall movements. Listen for breathing sounds and count respirations per minute for baseline data. Look for signs of nasopharynx or cyanosis, which indicate insufficient oxygen due to airway obstruction. Measure blood oxygen saturation and, if necessary, provide supplemental oxygen through nasal catheter or mask at 5 liters per minute. If chest movements are absent, initiate breathing with an ambubag. Perform cardiac massage if required, and consider intubation with an endotracheal tube. Connecting the patient to a mechanical ventilator for artificial respiration. In cases of abdominal distension interfering with breathing, insert an NG tube to decompress the abdomen, promoting full lung expansion. Under circulation, you need to assess the pulse and blood pressure to detect hypovolemic shock. Evaluate hydration status by checking for skin turgor, sunken eyes, or dry lips. Establish an IV line and administer fluids to restore intravascular volume, correct shock, and maintain electrolyte balance and nutrition during periods without oral intake. Monitor pulse and blood pressure every 15 minutes. Elevate the foot of the bed to improve blood pressure to vital organs and provide extra linen to keep the patient warm. Pain relief is a critical aspect of managing patients requiring emergency surgery, as they are often in severe pain. So administering pethidine helps prevent neurogenic shock caused by intense pain. Patients should be positioned comfortably to avoid pressure on the painful site. For those with a distended abdomen, as seen in cases like intestinal obstruction, Inserting a nasogastric tube can alleviate the distension, improve breathing, and reduce abdominal pain. Also, patients who are unable to pass urine should be catheterized to empty the bladder and relieve discomfort caused by the bladder fullness. Observations involve assessing the general condition of the patient and their response to the decision to undergo surgery. It is crucial to monitor vital signs, including temperature, pulse, respiration, and blood pressure to evaluate the patient's overall status and ensure they are stable for the procedure. Investigations are conducted simultaneously with resuscitative measures. Full blood count and hemoglobin levels are checked and blood grouping is performed. Clotting studies and blood urea nitrogen tests are also carried out. A specimen for urinalysis is obtained when the patient is asked to empty their bladder in preparation for surgery. If the patient is unable to pass urine, catheterization is performed to collect a sample. This process helps to rule out diabetes mellitus. Psychological care involves explaining the condition and disease process to the patient and their relatives, emphasizing the need for surgery and its immediate necessity as the only viable option. It is essential to outline the nature of the operation and the type of anesthesia to be administered. Addressing anxiety is crucial, ensuring the patient and their relatives accept the surgical procedure with confidence. Providing an opportunity for the patient to express fears and concerns is equally important, and this should be addressed appropriately to alleviate stress. Additionally, the patient should be informed about all the necessary preoperative investigations required before proceeding to the operating theater. The patient should sign consent if they are able to do so and if it is legally required to formalize the surgical operation. This ensures that the procedure is conducted with the patient's informed agreement and in accordance with legal requirements. Physical preparation for the patient involves gastric preparation, starting with the patient being put on new oral immediately. If the patient has eaten within the last 2 hours, a nasogastric tube is passed to evacuate the stomach content. In cases of intestinal obstruction, a nasogastric or duodenal tube is inserted and intermittent suction is initiated to keep the stomach or duodenum free of fluid and gas. The tube is left in place for continuous drainage. Intravenous fluids are administered as prescribed to maintain fluid and electrolyte balance and prevent hypovolemic shock. Ringer's lactate or normal saline may be given to support this. Physical preparation for surgery also includes bladder preparation to prevent urinary retention during induction and the operation, as well as to avoid accidental injury. Emptying the urinary bladder before surgery is essential, especially in cases of low abdominal or pelvic procedures, where a full bladder can obstruct access to the surgical site and increase the risk of damaging the bladder wall. In such cases, catheterization is recommended for continuous urine drainage and to monitor renal function, as studies show that renal and glomerular filtration rates can decrease by 31 to 77% during general anesthesia. Physical preparation also consists of bowel preparation, which, if ordered, involves administering an enema to cleanse the colon of fecal material. This step helps reduce the risk of fecal incontinence during surgery, as the muscles will be paralyzed by anesthesia, potentially contaminating the surgical field. Additionally, bowel preparation aids in preventing constipation and fecal impaction after surgery, which can be a common issue following anesthesia. Preoperative skincare is essential to ensure the skin is as free as possible from dirt, hair, cells, secretions, and microorganisms. This includes cleaning the skin with antiseptic soap and shaving the area to reduce the microbial population. Shaving is performed when indicated, depending on the type of surgery and the location of the incision site. These steps help to minimize the risk of infection and promote a safer surgical environment. Premedication is mainly aimed at reducing anxiety and minimizing the secretion of saliva and gastric juices. It also helps decrease gastric volume and acidity, which in turn helps prevent or reduce nausea and vomiting, ensuring a smoother maintenance of anesthesia. Prescribed premedication such as atropine and diazepam should be administered as directed to achieve these effects. Patient identification is a crucial step in preventing surgical errors. Upon admission, each patient is provided with an identity band that contains essential information, including the patient's name, age, diagnosis, ward, type of operation, and the type of anesthesia. This identification band helps ensure accurate patient identification throughout the surgical process, reducing the risk of errors and enhancing patient safety. It is important to remove jewelry and other items before certain medical procedures to ensure safety and prevent complications. Dentures should be removed to prevent choking hazards, while glasses or artificial lenses may also need to be taken off. Jewelry should be removed, especially in environments where a diathermy machine is used, as it can pose a danger. Additionally, nail polish should be removed as it can mask signs of cyanosis, which are important for monitoring a patient's condition. Before the patient is taken to the operating theater, they should be provided with a clean gown. This practice is essential as it helps minimize the risk of infection by reducing exposure to external contaminants. Additionally, a clean gown ensures that the surgical team has easy access to the operation site, facilitating efficient and sterile procedures. Providing the patient with appropriate attire is a key step in maintaining hygiene and ensuring optimal surgical outcomes. Once all preparations are complete and the patient is ready, inform the operating theatre staff and transfer the patient onto a stretcher, ensuring they are warmly covered. Perform and document the final vital signs observations in the patient's chart. Gather all patient records, including laboratory results, X-ray films, and medical notes, and ensure they accompany the patient to the operating theatre. So, at the scheduled time, a nurse escorts the patient to the theatre, introduces herself and the patient to the theatre staff, and provides critical information such as the patient's name, age, sex, diagnosis, and the planned operation. The latest vital signs and the operation site are highlighted for the team. Meanwhile, Prepare a postoperative bed, ensuring it is near the nurse's station for close monitoring. Equip the area with resuscitation equipment and necessary accessories, such as a suction machine, oxygen source, drip stand, a TPR tray, oral airways, needles, syringes, IV fluids, and emergency medications ready for the patient's return. When communicating with the family about the surgery, it's important to clearly inform them where they should wait and the expected duration of the procedure. Let them know the specific waiting area designated for families and provide an estimated time for when the surgery is expected to end, emphasizing that delays can sometimes occur. Also, designate a contact person or a hospital liaison whom the family can reach out to for updates during long surgeries, ensuring they have access to the latest information and reassurance as needed.